I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family. Afternoon, Jam. Nice to see you. Now, it feels like I haven't seen you via this platform for a while, but we've seen each other in person recently, haven't we? We had a nice trip up to London. So tell me what's been going on with you and perhaps a little bit about that visit to Westminster as well.
Yeah, hi Sal. Good to see you on the pod again. Yeah, we had a little trip to the corridors of power. We pressed the flesh. In all seriousness, it was a really interesting meeting, wasn't it?
Yeah, it was. It was kind of like an alliance, wasn't it, of all the sort of blood cancer charities coming together to help out with a working party. Which was really heartening, wasn't it, Jam? Met some lovely people there, and like you say, the seat of power. So nice to contribute to the conversation.
Yeah, and absolutely making sure that blood cancer is on the parliamentary agenda. So it was a really good day. But we're back recording today, Sal. So what's the topic for today's pod?
So today's an interesting topic in so much I think for you and I, this is absolutely our bread and butter, but probably is really important to our listeners and plays on their minds quite a lot. And that is, what on earth do my blood results mean? I know it sounds really simple, but, you know, we get so many queries, don't we, understandably about, wow, this result's a little bit off, or what does that mean? And how can, we interpret this? So hopefully we're going to walk our listeners through today exactly what all those red bits and black bits on your blood results mean, and the ones that we think you should pay attention to, and the other ones you could just put to one side.
I mean, how many times do we say, do you mind just having another quick blood test? Oh, sorry, we missed out this test. Do you mind just having an... I have to say, I mean, thank you to all of our patients who so patiently just have endless blood draws. But hopefully going through this pod will explain why we do it and the importance of navigating different bits of information from those blood results. But Sally, one really important thing that you touched on as well, some results are in black, some are in red. Appropriately, people are getting sent their results now and they can access them through the NHS app and other apps, and they can be quite scary to look at. So I think we're going to just try and disentangle some of the myths. And from our perspective as myeloma doctors, what are we really honing in on? And how does that help us look after you?
Definitely. And also to justify our vampiric tendencies of trying to, take blood every 2 minutes and why that's so important. So, let's get stuck in, shall we, Jam? Where should we start? Should we start with the red cells?
When you just look at any blood results, like, why is there a color coding sometimes? So some results will say black and it might say no action needed, and a result might be so-called out of range and in the red. Why does it look like that?
This is quite complicated, bizarrely. The red alerts, I guess they help us, don't they, as doctors when we're looking at the blood results, to really focus on the results which are abnormal. Now, I'm going to come back to that abnormal piece in a minute, but the black results are those that fall within what is deemed to be normal range. So those that you think, actually, this is what a healthy person's blood would look like, were the black ones, and the red ones are, well, this could mean that there's something else going on and there's another problem underneath. But it's really important to say that we talk about normal slightly differently here, and that normal here refers to what we call a normal range, which is what you'd expect for a healthy population, or 95% of those people within that healthy population. There might still be 5% who are still healthy, but their blood results don't quite stack up to that normal range. So it can be on some occasions, actually, your blood might be flagging red, but that's just normal for you because you're a bit different from the average. So, these are crude parameters. They give us a clue, don't they? They're a guide. But I guess our job is to interpret them in light of the individual in front of us. And is this normal? Is this abnormal? Is it important? Is it not? What does that mean? I do think that when you get those, those red results, they come through, it's the colour red. It's quite alarming, isn't it? It's like, oh my God, something's wrong. What have I done? How can I make this better? That's sometimes how they can be interpreted.
There will be a small proportion of the normal population whose results fall outside of what is called a normal range, but that is normal for them. Now, of course, for our patients on treatment or with myeloma, blood results are impacted by the myeloma and the treatment. But we're going to really run through, there's a standard sort of blood panel that myeloma doctors do very often, looking at a full blood count, kidney function, liver function, a few other salts that are associated with the bones and how well the bones are functioning. Of course, the myeloma proteins and measuring the myeloma proteins, which we have touched on in previous podcasts.
There is quite a lot to explore, isn't there? And I think so much, I suspect, of what we'll discuss, Jam, actually comes back to those CRAB features. So the C for calcium, the R for renal, the A for anemia, and the B for bone disease. And they unlock so much of the mystery behind myeloma blood results. But let's get stuck in. So
the red cells, the full blood count. So blood is made up of a bunch of different things. You have red blood cells, white blood cells, and different types of white blood cells, and platelets. And those parameters are looked at in a blood count. And not only that, there's a whole bunch of other information about the size of blood cells and the thickness of the blood and other things that are relevant in some conditions. But we really hone down to a few key things in our myeloma patients, don't we, Sally, when it comes to the full blood count?
Yeah, we certainly do. And I think when you look at the full blood count, which is just basically a lot of numbers, which, as you say, describe different aspects of the red cell. Now, just to remind our listeners, red cells are cells which make our blood red, and they're the ones that transport oxygen around our body. There's all these different numbers that are assigned to these different letters, often beginning with M, which tell us different things about those red cells, which exactly as you said, Jam, may be really relevant to one condition and one person. So, for example, if you've got sickle cell anemia, your cells might be a certain size or a certain shape, and those tests can tell us that. But if you've got myeloma, what we're actually pretty crudely interested in is, do you have enough red cells? And that number really relates to the haemoglobin. And that's the one we tend to hone in on, isn't it, really, in clinic? We look at the rest and we can talk our listeners through the rest. But actually, that number is probably the one which we think is most critical, because when your myeloma is active, you can't make enough red cells because your bone marrow, which is a factory for red cell production, is full up of myeloma. That absolute red cell number, the haemoglobin, goes down. And hopefully when your myeloma is in remission and your bone marrow is more healthy, the number comes up. So I think that's the one I focus on most anyway, Jam. I suspect it's the same for you.
The haemoglobin is a very important parameter. And for people on chemotherapy, the chemotherapy can suppress the haemoglobin. And sometimes we can offer injections such as this drug called erythropoietin, or EPO, which was made very popular by Lance Armstrong and other cheating athletes, unfortunately, because it's something that really boosts your blood count, but it can be amazingly effective in improving the hemoglobin level in our patients. A number of our listeners may have had to have blood transfusions as a quicker way of increasing the hemoglobin level. Sally, it's probably quite useful to just talk about other causes of anemia very briefly, because, of course, it may not just be myeloma that's contributing to the anemia. So sometimes people might be slightly low in iron or other vitamins, and there are ways of checking those results as well, which allow things to be changed, and that may also then improve the hemoglobin level.
Yeah, definitely. I think, when I think about approaching low hemoglobins, I think about it typically in a very medical way. I think it's the way we were taught. It's either because your body's not making enough, or your body's destroying what it's got, or it's losing it. And there are lots of different reasons why. For example, you might be making enough, might not be making enough. Myeloma might be one of them, or it could be that you've got an inherited blood disorder, which means your body naturally just doesn't make enough hemoglobin. Or it could be, as you say, that you don't have the key ingredients to make healthy blood, like iron or B12 or folate, for example. And then there are other conditions which can occur for lots of different reasons, where your body inadvertently destroys blood. And that might be because something to do with the heart, or some antibodies or proteins which are destroying the blood within your body. And then, of course, you could lose blood. You could lose it because you've had an injury, or because you're bleeding from your tummy. And there's lots of different reasons why. And actually, people might have lots of these things all at once. But often in myeloma, it really is as simple as, how high is your level? What does that say about the status of your myeloma? How is that person going to be feeling? And can this person go ahead and receive more treatment? And that's really what we're trying to look at, really, when we're looking at those numbers, isn't it, Jam? It's just like, how is this going to be impacting this person? Are they feeling it? Are they safe to continue at this level if it's low? And can they go ahead with their treatment, or do they need their treatment? So it's actually a really complicated area, and it takes a while. And I think this is why we actually had quite a lot of training when we were registrars, it takes a while to understand all these numbers. And it's almost like problem solving, isn't it? You're trying to fix something just through looking at all those different details.
Yeah, and anemia makes people feel rotten. You feel weak, you feel tired, you get breathless more easily, you might not sleep as well. And we have a number of good interventions to improve it. And as you said, Sally, the myeloma crab, A for anemia, is one of the main reasons why we see people as new diagnoses. They go to their GP and they're tired and they have the blood work done. And it's the anemia that then leads to the other investigations. And for people on treatment, so many different types of chemotherapy and other types of myeloma treatment can just what we call suppress your bone marrow function a bit, so you do get anemic. I think another important thing to say is that infections are something that we're going to spend sort of more time talking about, Sally, I think, as the year goes on the pod. After sort of a heavy episode of infection or other things that can make you feel unwell, anemia can be a response to that as well.
Yeah, it certainly can. I mean, infections can play havoc with all sorts of your blood results. And again, I guess we'll speak about that in a short while. But yeah, you do see that with anemia in particular. And something I always think, Jam, particularly when patients come to me with their blood results and they'd like them to be interpreted, I often think it's actually quite unusual for a myeloma patient to have a haemoglobin which is in normal range. That can occur if you've been in remission for some time and your bone marrow is nice and healthy and the myeloma is suppressed. But actually, a little bit of anemia is to some extent expected, I think, particularly if you're on treatment. And the other thing that's important to say is that we look at that absolute number, but when we're looking at these blood results, we're also looking at the trend. Has this changed from last time? Is it going up? Is it going down? Is it the same? That can help us kind of try and solve the problem so that the person, as you said, feels better. They can have their treatment, they can carry on with their life.
And that's crucial with all blood results. And that's why we, as you say, Sally, with your very beautifully worded, that's why we have our vampiric tendencies. So, the trend of blood results is, incredibly important.
That's where we'd action things. And that's also why we say, and I often say this to the people I look after, that if you feel poorly between appointments, particularly actually if you're being monitored and we're not seeing you so frequently, just get a blood test done, because it does actually tell us a lot and can give us a clue as to why someone might not be quite right. But of course, if you're on treatment for many, many years, you don't have to have more blood tests is absolutely necessary. Once a month is often more than enough. But if someone's in a slightly more precarious state because things are changing, we might ask some more blood tests just to monitor the trend.
So we've done the haemoglobin. Should we move on to the white blood cells?
The white cells.
So white cells. So very broadly, there are a number of different types of white blood cell. They are crucial in helping us fight different types of infection. So when you look at a blood count readout, you will see something called a total white blood cell count, which basically adds up all the different white cells. And then you will see a breakdown of all the different types. And there are lymphocytes and neutrophils and basophils and eosinophils and monocytes. And I'm probably going to stop there, but there's lots of different types. But there's one that we hone in on more than most, and that's the neutrophils. But broadly speaking, any infection or inflammation can make your white blood cell count go up or go down. Different types of infection can make different types of white blood cells go up or down. And you can see mixed patterns as well. And a very important part of the whole piece as well is the effect that chemotherapy has on white blood cells and especially neutrophils.
Yeah, I couldn't agree more. I mean, again, another really complicated area because these cells with their fancy different names, go up and down in response to different things. So some of them, for example, might go up if you're having an asthma attack or if you're allergic and you've got a bit of hay fever. Others might go down with chemotherapy, for example. So very dynamic situation. And therefore, the art is interpreting where they are, what's the trend, and what does this mean for the patient. And we get particularly interested in neutrophils because they're the cells that help us fight bacterial infections. So the bugs, I was going to say the coughs and colds, but coughs and colds tend to be viruses, but infections which can make you properly poorly, like a chest infection, for example, or an infection of the skin, they tend to relate to bacteria, and neutrophils help fight those infections. And so we look out for them being at a particular level so that we know that person has enough protection so that if they were to get an injury or pick something up, their body can recover from it.
For people on treatment, various different types of chemotherapy for myeloma, they suppress your bone marrow so you can't make as many neutrophils. And what we have learned from decades of giving chemotherapy for all conditions, blood conditions and also other tumours, breast cancer, colorectal cancer, is that you have to ensure that, of course, you give the treatment but you give the body time for the immune cells, the white blood cells, to recover before you give more. So a lot of the time people on treatment have blood counts so often because you need to sort of do these checkpoints to make sure, yes, the white blood cell count is okay or other parameters are okay to proceed with the next treatment. But the neutrophils are extremely important because the concern is if you give more treatment sooner, you'll end up with a longer period of a lower count and a higher risk of, potentially getting a serious infection.
Yeah, I couldn't agree more, Jam. So it's a sort of timing the treatment correctly and titrating or changing the dose according to their blood count response. And I guess a really nice example of this is when people are admitted for a transplant, because the melphalan we give them for the transplant to sort of try and get rid of the myeloma completely flattens that neutrophil count, and it keeps it flat for days. It basically falls to unmeasurable on our blood tests. And that's when the risk of infection is greatest. And we know the body recovers. That's why we give the stem cells back. But it takes time. And so we monitor those neutrophils like a hawk, because that tells us what to do if someone gets a temperature. Do we give them really strong antibiotics, or can we just give them tablets, where it might be coming from, and so on and so forth. So the regularity of the monitoring may also be dependent on how low we expect those blood results to go and how long we expect them to stay there. So, neutrophils are incredibly important, aren't they?
And we have GCSF. So these are these small injections that go under the skin that help the development and release of neutrophils from the bone marrow. So a number of you will have had GCSF, and it remains an extremely important part of supportive care for people on chemotherapy, during a stem cell transplant as well. After a few days, GCSF is started, and it's a way of getting that neutrophil count up a bit sooner.
I mean, it works absolutely beautifully. You can see this bump, can't you, almost straight away within a day or two, if your bone marrow can respond to it. And that's the other thing, without going into too much detail, but if you're slap bang in the middle of your transplant and the neutrophils have all been quietened down, you can give GCSF and it might not kick in straight away. You've got to wait until your bone marrow is ready to actually, respond to it and to recover. And again, the team around you will be able to tell you all about that. But something really important to say is patients often cotton on to the importance of neutrophils quite early on, actually, in their journey of myeloma. And it is something, again, like as we said, that we pay particular attention to. And some people do need regular GCSF. And we might counsel people, if your neutrophils are running a bit low, that if you get a temperature, don't just assume it's going to pass. Get in touch with us. And the reason for that is if your neutrophils are low at that time and an infection is beginning to occur within your body, sometimes it can take hold quite quickly. And that's where actually being seen by a doctor, being seen by your specialist could actually be quite important, just to make sure if you need the strong antibiotics, you get them quickly. So, we adapt our treatment according to how somebody's, blood results are behaving.
It should be said, though, that neutrophils can also go very high. And sometimes they go high because we've been a bit too liberal with the GCSF. So that's something that does happen and we've all seen. But also people who have sort of good marrow function, if they get very sick with certain types of infections, you can get a very high neutrophil count. And that's often something that you see in people who don't have bone marrow disorders. But it can also happen in people with myeloma. And as you say, Sally, the interpretation of blood counts is something that all haematologists have spent years looking at. But of course, we're trying to put it into context of myeloma.
Thank you for listening to the Myeloma Minutes podcast, proudly partnering with Myeloma UK. For more credible myeloma-related material and support, please visit the Myeloma website at myeloma.org.uk. That's myeloma.org.uk. Or call the info line on 0800 980 332, which you can find in this episode's description.
So we've been very focused on neutrophils. What about the other blood cells and myeloma? Do we spend a lot of time looking at them, or do we just hone in on the neutrophils?
Yeah, I mean, I think the other blood tests we do look at, I think in particular I pay attention to the lymphocytes. And the reason for that is a lot of the steroids, actually, let's use steroids as an example. Steroids are an anti-inflammatory drug, and they can also suppress, if they're given acutely, the inflammation that's sometimes helpful when you're having an infection. And they can sometimes suppress inadvertently the lymphocyte count, or if they're given alongside a low lymphocyte count, somebody might be at increased risk of, in this case, viral infections. So a person, if you've got a low lymphocyte count, may not have such a good response to a vaccine, or they may be vulnerable to viral infections, which we'd want to protect them against. And so, again, there are some treatments which we titrate or we give to patients if their lymphocyte count is low, and then we can stop when it goes up. And it's quite normal actually for people living with myeloma to have low lymphocyte counts. Actually, that's almost inherent within the condition. You've got this sort of lymphocytopenia. That's a fancy medical way of saying it. But again, that is dynamic and it changes depending on how your disease is responding. So I do pay attention to that, and that's because it helps in terms of that vaccination piece, but also in terms of stopping some treatments like cotrimoxazole, for example, which I give to people if their lymphocyte count is below 1, and I stop when it rises above 1.
And that's a special type of antibiotic that helps protect against a certain type of infection when your lymphocytes are low. So yeah, I think that's a really good point, Sally. These are the things that we're honing in on when we're looking at your blood tests, and then we will look at the platelets. So platelets are tiny fragments of cells that help stop bleeding. They're involved with basically making sort of clots and scabs. And for patients with myeloma, I think there's sort of two main contexts that we should talk about. Platelets can go low, again, when people are on chemotherapy or people have bad infections, for example. But for all our patients who are on immunomodulatory agents, drugs such as lenalidomide or thalidomide, we give blood thinning medication to stop the risk of blood clots. But when your platelet count gets below a certain level, it can be dangerous to give those bloods because it can increase the risk of bleeding. So we often look at platelets to try and do a quick risk-benefit analysis to check, is someone at more risk of bleeding or clotting, and are they on any blood thinning medication?
Definitely, and I think that goes through our mind almost every time we see someone. And I think it's fair to say that in any clinic, I'll see I imagine at least a third of my patients will be on drugs like that, so they'll be on these blood thinners. And so looking at that platelet count to make sure it's still safe to continue with the blood thinners, because if your platelets are low, you're at increased risk of bleeding. And if you're on a blood thinner, you're making that risk even greater. So it's really important to know when to pull back in that regard. And the other thing to say, Jam, and I'm sure, again, you've got a similar experience, is patients often come into clinic and they point out that they're getting just a few bruises, be that on their arms or their legs or whatever. And it's nice to know what could be causing that. Is it the blood thinners? Is it the platelets? Is it because they're just accidentally been knocking themselves and they just bruise more easily as they're getting older? So it's very useful as well to hopefully provide some reassurance when people notice these things occurring in their body. And finally, if someone's got a low haemoglobin, for example, if they're a bit anemic and you're thinking, is this the treatment? Is it the myeloma? Or could they be bleeding from somewhere? That's where that platelet count's also really important. It helps you interpret the other results a little bit as well, which is useful.
If we go back to the full blood count, when we're scanning these results, basically we'll focus often on hemoglobin, neutrophils and platelets. The other things are not unimportant, and there may be certain contexts where we look at them as well. But they're the three things that we're looking at often and regularly.
Yeah, definitely. And I would say particularly, actually, we haven't spoken about this because we don't want to confuse our listeners, but there's a lot of other readings around the anemia, the red cell bit, all these things we give them, MCV, MCHC, MCH. I mean, we do look at that. We can interpret it, but that is far, far less relevant. It's, as you say, Jan, those three things, hemoglobin, platelets and neutrophils, that for us are the ones that we really need to track and be cited on.
Should we move on to the kidney function, or colloquially known as urea and electrolytes?
So yeah, U's and E's are very important. Obviously, it's all very important, but it's important because this reflects how well your kidneys are working. And why does that matter? Well, that matters because we know that when your myeloma is active, there's a chance that your kidneys might slow down. They may not work so well. And in the event of that happening, what we tend to see is something called your creatinine, which is a protein which is filtered through the kidneys. So when your kidneys slow down, the creatinine in your body goes up, and that's picked up on the blood tests. So that tells us how well the kidneys are working. And so that kidney slowing down could reflect the myeloma and being more active again. It could reflect something much more routine, like you're a bit dehydrated or you've had a tummy upset and you're low on your fluids. But it's also really important because if someone's creatinine's gone up, meaning their kidneys aren't working so well, it may mean that we need to adjust the doses of the treatment we're giving to them, because actually lots of the treatment are actually filtered through the kidneys as well. And so we might need to change the doses to make sure we're not giving somebody too much or too little of a particular treatment according to the creatinine. So again, really important to interpret everything else, but to make sure that we are prescribing the right treatment and we know why.
That there are so many reasons why the kidneys may not work properly. And again, it's quite nice to signpost to future pods. I think later in the year, actually, we're going to do a whole podcast on the kidney, but it is a very important regular test. Is someone dehydrated? Is it related to the myeloma drugs? Certainly lenalidomide and zoledronic acid can be real culprits. Or very importantly, is the myeloma more active? And some of those sort of nasty light chains getting stuck in the kidney again. So it's a crucial part of our blood panel testing. With that as well, we look at other things like the sodium levels and potassium levels. People are often contacted sometimes because potassium levels are a bit low, and we have to supplement with what can be quite nasty tasting big chalky tablets. Apologies for that, but trying to keep all the salts and the kidney function in balance is a core part of myeloma care.
Yeah, it really is. And these things, again, they go up and down, and they might actually be changing, like the electrolytes you've spoken about, Jam, your potassium, for example. That might be changing because you can lose that potassium when you've got diarrhea, and you might get diarrhea because of lenalidomide, and you're on the lenalidomide because of your myeloma. Or it might be something that's got absolutely nothing to do with it, like you're on a water tablet and you lose potassium through the water tablet. So again, lots of different causes for these things being deranged, and we need to make sure that the levels are where we need them to be to make sure it's safe to go ahead.
Let's get to liver function. I always say never measure my liver function on a Monday morning. So this is the the classic thing, liver function, alcohol in the liver. So it's the thing in sort of common parlance, but liver function is really important. And again, it tells us a number of things about what may be happening to our patients with myeloma, and especially people who are on treatment. So what does the liver do, and what are we measuring in these liver blood tests?
Yeah, the liver basically helps to sort of break down toxins. It has a sort of a cleaning effect on the body, and it's also makes important products of the body as well. So it helps make synthesized proteins, for example, proteins to keep fluid within our circulation called albumin, or clotting factors, so small proteins that help our blood to clot. So it plays a number of key important roles, and we can monitor it, how well it's functioning pretty crudely, actually. One of the ways is through trying to look at, is it making enough of these proteins? Is it making enough albumin, for example? But we can also monitor, is it looking happy and healthy? Is it inflamed or not? And we do that latter piece by looking at something called the liver enzymes. And these, you may have seen these on your blood results, things like ALT, AST, ALP, tend to begin with A, and they reflect the overall health of the liver. Now, like everything in medicine, this isn't straightforward either, because the ALP, which is one way of looking at liver function, it's a type of protein or enzyme, can also reflect the bones as well. And some of the other liver results are only reflecting the liver, or some might particularly relate to alcohol consumption. So again, lots of detail in there. But crudely, I think people living with myeloma, it's not that unusual for your ALP to be a little bit on the high side. And that tends to just reflect the bony part of it, actually, rather than liver part of it. And the other liver protein levels or liver enzymes can go up and down, but they tend to stay at a pretty stable level unless there's a background issue with the liver. But it's important that we know about them because, again, drugs can be metabolized by the liver. So we need to know how well the liver is able to handle that and process those treatments. So that's why it's important. I guess it's not quite so vital as kidney function, but nonetheless, we need to do it.
It's really common for our patients to have ALTs and ALPs and even this other one called GGT in the red. It's really, really common. As you say, Sally, it's often because of the impact of chemotherapy drugs being what we call broken down or metabolized in the liver. It can be made worse by things like alcohol and a bad diet and diabetes and being overweight. But it's crucially one of these things that needs to be sort of monitored over time. And it's very, very common for drugs to be the cause of what we call abnormal liver enzymes. And we're often sometimes, taking drugs away or reducing the dose because, again, you have to ensure that the body's systems for, clearing and dealing with drugs, and that's typically the liver and the kidney, and it's different for different drugs, can handle what we're sort of throwing at it to control the myeloma.
Definitely. And again, it's all about the trend, really, isn't it? And seeing how that comes and goes. And it's really important to say that some drugs, I'm thinking particularly now about belantamab mafodotin, the Trojan horse drug. It's often mentioned that there can be a signal when you start taking that drug that your liver enzymes might flicker up a little bit. And we expect that. So we can interpret any change in light of that and in light of the treatment. So it's understanding the drugs, it's understanding what these particular results mean, and is it important? But like you say, Jam, in most cases, actually, the results might be in the red, but we don't necessarily need to do anything about it. We just need to monitor it.
So should we move on to calcium, Sally? So calcium is crucial in myeloma. It's the sea of crab. Sometimes the first thing we know about someone having myeloma is that they have a high calcium level that has been detected in the blood. Now, we monitor calcium very regularly throughout our patient's journey with myeloma, of course, to see if the calcium is going up, which could indicate, of course, a new diagnosis, or that the myeloma is becoming more active or treatment has stopped working. But Sally, what actually happens quite often for people in remission is, bizarrely or conversely, their calcium ends up being a bit low. So can you explain that?
Yeah, it's a bit of a fiddle, this, isn't it? So we end up dishing out calcium tablets, don't we, which seems somewhat counterintuitive. And that's partly because, myeloma lives within the bone, and bone turnover is affected by myeloma. And we help control the myeloma with chemotherapy, but also with this drug, which we've spoken about before, zoledronic acid, more often not, that's a drug that's prescribed, to help kind of calm down the bones and that bone destruction, to help the bones heal. But that treatment can lower your calcium levels, and it can lower your calcium levels sometimes a little bit too much. So we need to prop up the calcium level with calcium tablets. And really importantly as well, as somebody's at risk of their calcium levels being too low, if their vitamin D is also too low, which is another really important part of sort of that calcium control within the body, it's metabolism. And so we often give calcium and vitamin D together to help keep those calcium levels up so that it's safe to carry on with the treatment that's needed, and also to keep the body safe. Low calcium, you need to pay attention to it. It's important. If it goes too low, it can be quite worrying.
And can make people feel extremely poorly. Certainly giving zoledronic acid without replenishing calcium can lead to, very low calcium levels, which can certainly lead to feeling unwell in a number of ways, and people needing to, be admitted for calcium infusions and things like that, which we try to avoid. So there are other salts that we look at in the blood as well, such as what we call phosphate levels and magnesium as well. But these generally have less of a sort of week-to-week and month-to-month impact on us.
Yeah, they do. And I think often you can, while these levels often actually they do often run a little bit low, you can treat them with supplements and there's no urgency in doing so. Whereas something like calcium and potassium, actually, if they're very far outside what we consider to be normal, you have to action that. And the other thing to say is, and it's really important to say this, is that obviously all these things are related to each other. A high calcium level can cause kidney failure. Kidney failure can cause anemia. And this might all be driven by your myeloma, for example. And so actually, often we look at one result, like a calcium level, we see it's up. And then the first thing I'll go to is then, oh my goodness, what are the kidneys doing? And I'll look at the kidneys. And then I'll think, okay, where's the paraprotein? What are the light chains doing? So you're interpreting all of these results together to try and build up a picture of what's actually going on here on the blood tests. Then integrating that, or bringing that together with how the patient's feeling and what they're telling you, to hopefully come up with a plan going forward. So, everything in literally black and white, or in this case, black and red, might look very simple, but actually it is quite complex, isn't it, Jam? It's a detective piece trying to untangle it all.
Indeed it is, but there are lots of familiar patterns that have interventions that allow things to recover quickly, with the aim, of course, of getting to the diagnosis quicker, giving the treatment on time, and making people feel better. Last but not least, paraprotein and light chains. Now, of course, this is the, in some ways, the essence of myeloma blood tests, and we have spoken about this at some length. But of course, these are done often and regularly to monitor response to treatment, to see whether the disease is getting more active. And understandably, sometimes that's the blood test that people hone into first before they look at anything else, which is totally understandable.
Absolutely, it is, isn't it? That's what you want to know, because that almost, it feels like that tells you your fate. That tells you what's going to happen over the next month, how worried you need to be or not. But again, goodness, there's always and another thing here, isn't there, in this podcast in particular. But these results can be dynamic as well. And they, for example, your light chains, if your kidneys are slowed down for another reason, like you've had a tummy upset and you're a bit dehydrated, your light chains might actually read a bit higher than they normally do. We'd expect that. So again, these results are integrated with the rest of the blood results, which allow us to get a clear picture about what's going on. But yes, we hope that we see the paraprotein, the light chains falling. And what we'd hope is, as they do fall, that the other blood results fall more into line or closer to those normal ranges.
What we've tried to do is give a dynamic understanding of why we bleed people so much and the kind of reasons that blood tests done regularly are important. We're looking for trends, we're looking for patterns that we understand, all these different aspects, the blood count, the kidney function, the liver function, different salts such as calcium, and of course, the paraprotein and the light chain results help us look after people safely and carefully over their journey with myeloma.
Yeah, absolutely. It sort of guides us through, and it's a really important tool in our toolbox, so to speak, to understand what's going on and to know how to action it. And I'm always really pleased when people come into clinic with their blood results, because it shows, first of all, that they are very active in understanding what's going on in terms of their health, but also it's an opportunity to really talk about myeloma and how it behaves and it's behaving for them. But it is a complex area. As we've been speaking, Jam, I've just been going through my mind thinking, God, this is actually quite hard to put into words. It can be quite confusing. It can be quite overwhelming. But as we've often said on other podcasts, if you find yourself in that situation, hoping that everything will be black, but realising it may never ever be black, just talk to your doctors about it, or your nurses or your specialists, and they'll be able to talk you through. And actually the results in front of you might be pretty amazing for you. It might be just where you need to be, even though they're not necessarily reading as being within normal range. So listen to the experts around you, quiz them, and we'll all learn together. That's how I would interpret this somewhat confusing area of medicine.
Totally, but when you break it down, there are lots of familiar patterns that people looking after myeloma should and do understand. Having that information and understanding it better helps your dialogue with your doctor and hopefully improves your care. So that is what we want.
Couldn't agree more, Jam. Absolutely. So, and I think this is going to happen more in the future. We're all going to have our doctor in our pocket, aren't we, on our mobile phone with our results? So yeah, let's bring it on and as I say, really learn together.
Absolutely. Sal, thanks. Lovely to chat about blood results. I'm going to go and look at mine now.
Check out those liver function tests. It is a Monday, Jam. Watch out.
It is a Monday. It is a Monday, indeed. Sal, lovely to see you, and I'll see you at the next one.
You too. Take care. Bye.
See you later. Bye. This has been the Myeloma Minutes. We hope you found this week's pod engaging, interesting, and above all, understandable and genuinely useful. If you enjoyed today's episode, please follow the podcast and share it with anyone who might benefit, from your online support group, your medical team, to friends and family. And as always, if you have questions or topics you'd like us to cover in the future episodes, please do get in touch. You can find us at www.themyelomaminutes.com or email us at themyelomaminutes@gmail.com. And you can find us on social media by searching The Myeloma Minutes on Instagram and Facebook. Many thanks for listening, and we'll see you at the next one.